Hi, everybody. Thanks for joining the November 2024 VTC Wellness Medicine Journal Club. This month's session is covering Immersion Pulmonary Edema, otherwise known as SIPE or IPE. I am relatively knowledgeable about most topics in wilderness medicine, but this is definitely one where I'm relying on some outside help here. So I've got a medical student, a resident, and both of which have done work in IPE and will be presenting an article as well as a lecture on the subject. Then we have Dr. Moon, who was the author of the article, joining, hopefully lending in his experience as well. And Dr. Moon is the medical director of the Duke University Hyperbaric Center and has quite a few other titles. But I think tonight is somewhat of a rather academically unique topic. I think a lot of people may have heard the word IPE, but might not know exactly what that entails. So I'm going to hand things over. I'll be kind of hosting and chaperoning the night, but I think we can start off. Matt, if you want to give us your lecture, I think that would give us a great intro and overview of the topic. And then we can hand off to Harrison from there. So I'm going to mute myself, and Matt, feel free to share your screen and take it away.
Perfect. Sounds good. Evening, everybody. I'm Matt Christensen. I'm one of the fourth-year emergency medicine residents at Naval Medical Center, San Diego. Excuse the background. I'm in one of the ICU call rooms for the month that I essentially live in this hospital. So I was fortunate enough to do a little bit of background research and put this presentation together for a grad rounds for my hospital, and I was able to adjust it for this audience as well. So are you guys able to see my slides, or are you still seeing me on screen?
Yeah, we can see you.
Awesome. So the title of my talk is going to be Swimming-Induced Pulmonary Edema and its Implications for the Naval Special Warfare Candidate community. As I said, I'm a fourth-year EM resident at Naval Medical Center, San Diego, and I have no disclosures for this topic. So starting with the objectives for this discussion, by the end of this talk, you guys will be able to define swimming-induced pulmonary edema. We will together review the epidemiology and pathophysiology of this condition. We will discuss how this presents clinically and the important differentials that you have to remember. We will outline current best practice recommendations. We will review the published clinical practice guidelines from the relevant specialty societies. And you as the audience will be able to understand SIPE in the context of military training and the operational environment. So to define our topic, SIPE is a clinical condition that's characterized by the acute onset of pulmonary edema during or shortly after swimming. This is confirmed by key clinical features and imaging findings that we will discuss, and resolution of this pathology is expected within 24 to 48 hours. It's also, as Justin said, kind of used interchangeably, the terms swimming-induced pulmonary edema and immersion pulmonary edema. They're both used to describe the same clinical picture. The pathophysiology, honestly, bottom line up front, it's a very poorly understood mechanism because it is either it's not clinically significant enough to cause a patient to present like for medical evaluation, and the patients that just have a very poorly understood mechanism for why this happens. It's suspected that the increased extrinsic chest pressure from your body entering the water leads to increased pulmonary arterial pressure, which causes microvascular trauma, increased permeability of that vasculature, which then results in a transitive pulmonary fluid shift and the pulmonary edema that you see presenting clinically. This can then be further compounded by your chest compressed by the wetsuit, as well as the increased respiratory rate that occurs with exertion, as well as it's associated with cold ambient air temperature. Now, the current literature emphasizes that it's cold ambient air temperature. It's not dependent on the actual water temperature. And this is suspected to be related to the same kind of pathophysiology of in asthma or status asthmaticus, where you dry out your airway, the cold air releases inflammatory mediators that cause further membrane damage and further increase the vascular permeability that results in this pulmonary edema. Going through some of the epidemiology and risk factors, it's important to understand that this is not depth dependent. So scuba divers or deep sea divers are not at a greater risk than you are swimming at the ocean surface. The risk factors that are associated are either having a history of that condition. It's about 3 to 5 times more likely in females, which is suspected to be related to underlying mitral valve regurgitation. It's also been associated with strenuous immersed exercise, hypothermic conditions, overhydration, and a past medical history of asthma. And it's also been recognized that the incidence of this condition happens much more often in candidates for military special warfare like Navy SEALs, Green Berets, and the Air Force special operators. In fact, the incidence of this condition is as low as less than half of 1% from the European community that published a study on this particular annual Swedish swimming event. The kind of average that I found was about 1 to 1.5% in American triathletes, but there's literature published from my own backyard here in San Diego, California, where SIPE happens as often as 5%, 1 in every 20 Navy SEAL candidates. And when you think about why, I can't imagine why, right? It's not like the majority of these risk factors apply to this community. It's not like they're undergoing strenuous exercise, often immersed conditions, probably hypothermic, maybe overhydrated. Maybe they hid a past asthma history from their recruiter just because they wanted to give it a shot at becoming a Navy SEAL. I'm sure that none of our current special warfare population falls into those categories. But there's also been some literature out of the Navy special warfare medical community that has a couple of extra unique considerations. In particular, this study that was published just about a year ago compared the characteristics of patients who experienced SIPE from a military active duty population and patients who experienced SIPE just as a normal non-active duty civilian, regular recreational diver. And what they found is that the patients that were undergoing either mild, moderate, or intense physical exercise, the patients that experienced SIPE fell into the intense physical exercise category in 86% of the active duty military divers. For the individuals, the civilians, the non-active duty folks who experienced pulmonary SIPE, this happened with either mild or moderate. So the reason this is important is it demonstrates how the amount of exercise and the level of physical exertion that you are pushing your body to increases the risk of experiencing this condition. There's also some literature published. I want to highlight the author, Ben Sobreros, because he's a subject matter expert who will come into play later in my talk. Having an upper respiratory tract infection also increases the risk of this. They found that 80% of the Navy SEAL candidates who experienced SIPE had an underlying respiratory disease or an active URI at the time of their SIPE episode. And they also had they had 2 twins going through Navy Special Warfare selection training, and those twins both experienced SIPE within 30 minutes of each other while undergoing the same, special warfare candidate selection trial in this particular swimming exercise called the Crucible. So it also demonstrates that there is some sort of underlying genetic predisposition to this, considering they had 2 monozygotic twins that experienced SIPE within 30 minutes of each other under the same kind of extensive strenuous conditions. Again, published by Dr. Ben Sobreros. So how does this clinical picture present? Well, kind of as you would expect pulmonary edema to present. Patients are short of breath, they have a cough, pink frothy sputum, hemoptysis, and some hypoxia, with the general literature that I reviewed calling hypoxia less than 95% to be considered a positive finding. Whereas this characterization study published out of the Navy Special Warfare medical community a couple of years ago, same kinds of symptoms with about the same incidence of symptoms, where the patients have either cough, a third have pink frothy sputum, about a quarter have hemoptysis. They defined hypoxia as less than 90%, so a much lower incidence of that. But these patients also have abnormal lung sounds on auscultation, either rales or wheezing, but abnormal one way or the other. Now, your differential diagnoses for this has to be fairly broad, because what you can't miss is a drowning event or a submersion injury. And the reason that's important is because the management is different. Not significantly different, but as we know, in a drowning event, that's the one contaminated airway that you don't want to suction, because you don't want to pull all the surfactant out of that airway. So you need to clarify as best as you can if this patient was submerged for any period of time and may have experienced a drowning event, or is this more likely to be a swimming-induced pulmonary edema kind of a picture. The other differentials to consider are all the standard diving emergencies. Did your patient experience an arterial gas embolism? Is this decompression sickness? Are they experiencing pulmonary barotrauma? Is this a potential SCAPE picture? Did they have an underlying respiratory symptom illness over the last few days that they hid from you, and they are actually finally turning the corner on a pneumonia? Did they have a spontaneous or traumatic pneumothorax based on whatever training they were undergoing? Did your patient experience an acute MI, or did they blow out their mitral valve and now they're in cardiogenic shock? Did they throw a clot and now they have a PE? Are they dissecting? Did they experience aspiration pneumonitis? Again, if they had an underlying undiagnosed asthma, or they hid an asthma diagnosis, is this a status asthmaticus kind of a picture? All the things that you guys need to be able to consider if you have a patient with these symptoms presenting to your ED, to your medical clinic, or wherever you might be. So how do you diagnose this? Well, easy. It's a clinical diagnosis. If a patient presents to you and you suspect that SIPE is a possibility, you do all the same things that you do for any other respiratory distress or possible submersion injury patient. You establish your IVs, you put them on the monitor, and you get a continuous pulse ox. You'll probably, and I would recommend, ordering all your standard bedside analytes, get a VBG with electrolytes, get your finger stick sugar, get an EKG, draw and send your rainbow labs, including a BNP, and then get some imaging. You'll see a lot of the literature talk about chest x-ray, but as we know, especially from the emergency medicine community, in a chest x-ray with pulmonary edema, you'll see the bilateral fluffy infiltrates, but a more useful bedside diagnostic modality would be ultrasound, where if you're looking specifically for pulmonary edema, ultrasound is 88 to 96% sensitive, whereas a chest x-ray is significantly less so. And when you're looking on ultrasound, what you're going to find are B lines. You can call your clinical picture pulmonary edema when you've got 3 or more of these B lines that extend from the anterior edge of the lung tissue all the way through the posterior end of your viewing field. And when I think of B lines, the way that I like to teach my juniors and my learners is, think of your healthy lung tissue like an attic. And if you've got a bunch of schmutz or dust or other contaminants up in your attic, when sunlight shines through the window, you're going to see the individual rays of light. If it's a nice, open, clear attic with no dust and no debris, it's just going to be a fully lit room, and you will not see individual beams of light. You can think of your lung tissue as the same way. If you see these B lines, it's because there's something confounding your picture that doesn't belong in a healthy lung. So what do you do about it? Well, when your patient first arrives, you do all your same standard of care to get your patients settled into your department. Take the wetsuit off, dry the patient off. If they're hypothermic, then start to warm them. But if you're fairly convinced that this is a swimming-induced pulmonary edema case, all you need to do is support their oxygenation status. And really, the current recommendations are non-invasive positive pressure ventilation, not necessarily with BiPAP, but with continuous positive airway pressure. And the data shows that your patients will experience relief of their dyspnea in as little as 10 to 15 minutes on just 10 of CPAP. And this is supported in the military community by a study published through the Air Force, including this gentleman, Dr. Tanaka, who's now one of my staff here at the Navy Hospital, which had a case series of candidates for the Air Force Special Operator community. There were 11 patients who experienced swimming-induced pulmonary edema. They were treated with up to a max of 30 minutes of CPAP at 10. And of those 11, all 11 returned to training. 8 of those 11 returned to training that same day, and not a single one of those individuals experienced any recurrent episodes. And the reason this is important is we consider, BiPAP and CPAP to be a fairly high level of oxygen support. And typically, these patients, if you put them on CPAP or BiPAP from the emergency department, they're going to stay on that until they're evaluated by the ICU because there's, you suspect that there's a high risk of clinical deterioration. But SIPE seems to be the one clinical picture where that is not the case. And if you're able to stabilize your patient in the acute setting, they are not at risk of rebound symptoms the way that you think of rebound symptoms in like an anaphylactic case or something to that effect. The other thing that's important to remember is even though this is pulmonary edema, it does not react the same to the treatment for example, cardiogenic pulmonary edema, meaning there's no literature, there's no evidence that supports the use of diuretics or nitrates. It's purely this positive pressure ventilation that is shown to resolve these cases. So what does the current literature say besides the case reports and some of these individual studies? Well, there's not a whole lot, whether you are an emergency medicine doctor who was trained on Tintinallies. Well, this is a 2,000-page textbook that only has one paragraph on immersion pulmonary edema. And it mostly discusses the background, but it highlights that the cause is unknown. And if you're from the Rosen's camp, again, 2,700 pages, you can search the table of contents, and whether you call it swimming-induced pulmonary edema or immersion pulmonary edema, it doesn't even discuss that topic specifically. Now, of course, Auerbach does go into greater detail. It's 2,800 pages, and even though it also only has one paragraph, it at least discusses the proposed mechanisms. Like we said, it's strenuous exercise elevates that pulmonary artery pressure and presumably causes this capillary fragmentation. But the good news is, even though a lot of these specialty societies, including the American College of Emergency Physicians, who don't have any clinical policies on SIPE, we have guidelines from the Wilderness Medical Society that they outline 16 pages of your submersion injuries and 2 paragraphs on swimming-induced pulmonary edema. You don't have to do a whole lot for these patients. Like it says here, they usually recover well without treatment. And in the absence of severe respiratory symptoms, you might not even have to evac your patient if you're forward deployed or if you are, for example, the standby medic for a wilderness medicine race. If you can get your patients on some sort of positive pressure and their symptoms resolved, the risk of them deteriorating again or having rebound symptoms is just not suggested by the current literature. Now, the military also follows these joint trauma system clinical practice guidelines for how we manage various clinical situations in a forward deployed setting. And the drowning management CPG is 21 pages, and they have about 1/3 of a page on swimming-induced pulmonary edema. And again, they also highlight the importance of distinguishing possible SIPE from possible drowning because you want to treat those airways differently. But again, the management, fairly supportive, resolves with rest 24 to 48 hours after the initial insult. If you really need to hospitalize them for oxygen support, you can. And again, the current literature does not support the use of diuretics in these cases. Now, the reason I had mentioned Ben Sobreros earlier is because he is a colleague of mine. He's someone that I work with fairly regularly, at least a couple times a month. And he was the medical director or the undersea medical officer who ran the Naval Special Warfare BUDS Medical Clinic for many years. And so I asked him, hey, since there's so much literature related to SIPE that's coming out of your medical clinic, can you send me a picture or whatever resource you guys use for your standard treatment algorithm? And then this is what I got. They don't have a specific algorithm when these kinds of patients present to their clinic. They treated very mild symptoms that were not hypoxemic, just with observation. And the patients that were in respiratory distress or that were briefly hypoxic, they did what we discussed. They give them some supplemental oxygen, maybe some duonebs, and if they didn't improve with that, they would put them on CPAP. They never gave diuretics, and neither should you. But again, this clinical picture, even though it can look very concerning when you get an initially dyspneic respiratory distress patient hitting, you're hitting your triage or being presented by EMS. If you can just remember how valuable positive end pressure, the CPAP for this kind of a clinical picture is, then you can turn these patients around very quickly. So in summary, SIPE, it's an uncommon but potentially life-threatening condition that we don't understand completely. And you have to remember to keep this in your differential for any patients that are undergoing strenuous immersed exercise. But even though it's a clinical diagnosis, you can use your lung ultrasound, you can manage this patient's airway, and as long as you can trust your CPAP, set it to 10, you can take care of this clinical picture. So these are my references. If you guys have any questions, I'm happy to answer them.
Matt, Richard Moon here. That was a very nice summary. Fantastic, in fact. Just one point, and that is amongst the military population, you're not going to see this, but there are a large number of cases of SIPE associated with Takotsubo cardiomyopathy. And while I totally agree with your philosophy on diuretics, you don't need it. For those individuals who have acute cardiomyopathy, they may behave or have a component that is exactly like standard cardiogenic pulmonary edema, and they may need diuretics.
Awesome. I think that's a great point. I appreciate you contributing that.
Yeah, I agree. Great job, Matt. This is part of the reason I choose topics like this is because, I mean, you talk to one of the people who does research on this quite a bit, and even his shop is like a paragraph and a 3-bullet point treatment plan. So I'm not saying this is like unheard of, but I don't think people talk about it as much as they probably should. Any questions before we move on to this month's article, or just general questions about IPE or SIPI?
One of my big questions, Dr. Christensen, in talking with some individuals coming out of the military and military medicine, especially in some of the Navy SEAL candidates, is like the true loading up of water before going into like BUDS training. And have you kind of seen some of that? I work a lot with triathletes who don't necessarily have the same amount of hydration right before, but I've heard anywhere from like 5 to 7 liters going into a day of training.
Yeah, I don't have data to that kind of a nuanced level to share with you, but I do know that they associate overhydration with a fair amount of these cases.
Yeah, just Richard Moon again. We've actually studied the effect of hydration in individuals who've had SIPE before. And what we did was, we haven't published this stuff yet, but Our routine is to exercise people head out in cold water, 20 degrees centigrade water, for up to 40 minutes and see what happens. If they get sight, then we pull them out, of course. But when we repeated the study by fluid loading them beforehand, there was a much higher incidence of sight in that particular model. So in triathletes who come to see us and they want advice, I always tell them, look, wait until the bicycle before you fluid load. Don't fluid load before the swim.
And to
Thank you.
touch on the most recent chat message here, I think this is another good point where just general treatment for, let's just say, pulmonary edema in general, your colleagues, your nurses, your residents, your students, even yourself are going to have that gut feeling like, oh, it's pulmonary edema. I should probably just put them on BiPAP or CPAP. I should probably just give them Bumex, Lasix, get RT down here, because your team is going to be just flabbergasted if you're like, nah, we're not going to do diuretics, because that's just what everybody's used to. I've seen it with the envenomations, the drownings, the heat strokes, the hypothermias I've treated. And if it's not the standard thing and you're treating somebody that you think is going to be a little bit outside the norm, I like to kind of if you get a minute, prep your team, say like, hey guys, this is going to be a little weird. We're going to be doing some stuff we don't normally do. So if you can take just a second or two to do that before, your team will feel a lot more comfortable about doing the stuff that cases like this would need. Like when I had a heat stroke patient, I got the body bag out. I had sent security to go get ice, and the team was like staring at each other for a minute before we did it. Not that this is as like, as gut-wrenching as something like putting somebody in a body bag, but it's different, so just remember that when you're working with your colleagues. With that being said, I think we can transition to our article. Harrison, take it away, and Dr. Moon, please feel free to add any background information or any follow-up studies you've done since to kind of add further information. Take it away.
I'm muted. All right, there we go. Is everyone able to see my screen? Cool. All right. Hi, everyone. Very, very excited to be here presenting Dr. Moon's research, and very happy to be here with you, Dr. Moon, and for everyone. My name is Harrison Steins. I'm a third-year medical student at Rocky Vista University. I am very excited to be talking on this topic, as I've actually used your research, Dr. Moon. My research interest right now is swimming-induced pulmonary edema, and currently I'm interested in trying to better get a hold of the idea of incidence. So I'm paired up with Ironman right now, and I go to a lot of Ironman events, just ultrasounding symptomatic and asymptomatic individuals, trying to get a better handle on who actually has at least B lines notable on ultrasound, whether they're symptomatic or not, which is interesting because it's a bit higher than we see in the literature. And Dr. Christensen, you mentioned that Swedish study out of the 46,000, but only so many of those were actually ultrasounded, only a couple hundred, which was interesting compared to the total number of people that they included. But today I'm here to present the journal article, Swimming-Induced Pulmonary Edema, Pathophysiology and Risk Reduction with Sildenafil, which was published March 8th of 2016 in the journal Circulation, so American Heart Association journal. So diving into what we're talking about, and thank you, Dr. Christensen, for the awesome introduction and overview to swimming-induced pulmonary edema and CYPR-CIPI, which I like as well. So again, it's the pulmonary edema condition that includes dyspnea, hemoptysis, hypoxemia, generally resolves within 24 hours. But as we talked about, the pathophysiology is not fully understood. Otherwise, healthy individuals, some life-threatening cases have been reported, fatalities in divers, swimmers, endurance swimmers, scuba divers, Navy SEALs. And among the combat swimmer trainees, it's between like 1.8 and 6%. So again, the proposed pathophysiology, not totally divvied out in the literature, but blood shunting to the core from cold water immersion, negative pressure breathing, reduced cardiac compliance, increased peripheral resistance, and physical exertion. And then proposed risk factors are the cold water, negative static lung load, exertion, fluid loading, and low vital capacity. And this is kind of an overview slide that is a good visual representation of what the article talks about as a background for a site. So again, looking at how we can clinically diagnose site, it's that acute onset of dyspnea or hemoptysis immediately or during or following swimming, and then chest radiographs consistent with the alveolar filling process or interstitial pulmonary edema resolving within that 24 hours. We're not talking about history of water aspiration, laryngospasm, but as said before, there may be a previous history of preceding infection. And then the hypoxemia, as defined in some of the literature, is either 95%, 90%. What I have seen up here in Colorado at some of Ironmans are that people are going into Ironman events or athletic events at elevation, say Boulder at, just over 5,000 feet. And without stepping foot in the water, they're already at, 91, 92% oxygen saturation. So I think hashing that out in the literature is an important thing to start doing. So moving forward to the article, the initial hypothesis was that SIPE-susceptible individuals have a higher mean pulmonary arterial pressure and pulmonary artery wedge pressure during exercise in cold water in comparison with the general population. And then as a secondary question was, can prophylactic sildenafil attenuate the increase with the aim of reducing the risk of SIPE? So sildenafil being used either in the acute management or in the reduction of SIPE from reoccurring. So the study design took 10 healthy individuals aged 18 to 55 years old with a history of 1 or greater episodes of SIPE, recruited from a group of 71 who were screened for the study. And they compared them with 20 control individuals with no SIPE history. I think that the research article does a great job of describing fully each of those 10 symptomatic or individuals who have had SIPE before. They go into their athletic history, whether they were triathletes, the type of exertion that they do. And in order to standardize both, they looked at the physicals, tried to compare chest radiography, spirometry, so lung vitals, forced vital capacity, expiratory volume, FEV1, and mid-expiratory phase, and then trying to rule out any cardiac causes of pulmonary edema. Everyone received a 12 lead EKG. So you can see the average age for the SIPE susceptible was 41 years old, and the controls was 36 years old. I will say that in the there were differences, which we'll talk about in the limitations in the gender of the participants. We saw more males than females in this, which may not reflect the incidence of SIPE as it exists in the literature. So the study design sought to collect some data on heart rate, MAP, MPAP, pulmonary arterial wedge pressure, the expired gas volumes, arterial ABGs and BBGs, and then these were the statistics that were used to compare. So an unpaired t-test for the continuous variables, Fisher-Exact test for categorical, and then repeated measures analysis of covariance for the hemodynamic responses, which had a couple of variables and conditions. So moving into the study design, how it started was the day prior. There was a dry exercise on a cycle ergometer to 150 watts and familiarization with the immersed environment, which we'll show pictures of. And looking at the pictures, they weren't in the article directly, but I found a Duke article that had posted, so we'll kind of work through or look at how the study was set up in real life, which was really cool to see. So this day prior to the study, familiarized all of the individuals with the actual study and then got their capacity for work. The next day, supine dry measurements were taken, and then there was a rapid submersion in a dunk tank. And this rapid submersion was for the 10 controls and all of the SIPE subjects on a board laid down with a scuba tank so that they were able to breathe air. So from that, it was measured the heart rate, the MAP, the MPAP, and the pulmonary arterial wedge pressure, and that was measured before submersion and then 1 minute after. So then the individuals got onto the ergometer for 6 minutes at 60 revolutions per minute. So they were moving to simulate that exercise. The water was 20 degrees, and the amount that they were moving was based on the estimated exercise capacity that was calculated the day prior. All of these measurements were repeated at 5 minutes and at rest for the controls. They were not repeated for the SIPE individuals at rest to decrease the incidence of possibility of SIPE again. The expired gas volumes were collected over 1 minute during minutes 5 and during minute 6 of exercise. It didn't go into how exactly, but I'm assuming it was from the regulator. But Dr. Moon, after I would be very interested to see like were they taken out or was it from the regulator? And then the mixed O2 and CO2 were collected and analyzed with mass spec. The ABGs and mixed VBGs were collected and analyzed to calculate the oxygen consumption and then the cardiac output. And then finally, the post-exercise SIPE subjects were given 50 milligrams of sildenafil orally, which in looking up some previous research had been doses that other individuals had received, either post-SIPE experience or if they were triathletes taking sildenafil after one event of SIPE training for more triathlons. Then those individuals repeated the entire protocol 150 minutes after the administration of the drug. And then after that exercise, the individuals were examined again. So here is the volunteer going underwater, pedaling on that ergometer. And then they were having their mean arterial and pulmonary artery pressures, as well as cardiac output and oxygen consumption measured. And that black large tube, I'm assuming, is the regulator coming down for those oxygen measurements. So moving to the results, both MPAP and PAWP were higher in the SIPE group than in controls, and these were the statistically significant values. So we also see that after the sildenafil, there's a significant decrease in the pulmonary arterial pressure, but neither MPAP nor POP in the SIPE group were significantly different from the controls. So you can see on table 5 here, the numbers with the stars are the significantly different. So in the MPAP on the pre-sildenafil versus control, we see that. And then the post-sildenafil versus pre-sildenafil, we see that as well for all systolic, diastolic, MAP and MPAP values. Here we see that after accounting for the differences in cardiac output, both the mean pulmonary arterial pressure artery pressure and the pulmonary artery wedge pressure were higher in the SIPE groups than in the controls for the exercise, and those were statistically significant. After sildenafil, there wasn't a significant, there was a significant decrease in pulmonary arterial pressure, but not mean pulmonary arterial pressure nor pulmonary artery wedge pressure in the SIPE group were significantly different from the controls. So the differences in mean arterial pressure, central venous pressure among the groups weren't statistically significant either. So what's this all mean? So the study found that increases in mean pulmonary artery pressure and pulmonary artery wedge pressure during exercise were seen in individuals who have experienced SIPE. And SIPE-susceptible subjects were not working as hard as the control subjects, even though their MPAP and POP values were higher. So I think that this is important to look at individuals who have experienced SIPE before and thinking about some of that unknown pathophysiology of why SIPE is actually happening. It's not because those individuals were working harder. It is because of possibly some of the other extrinsic things that we talked about. So going into cold water, shunting blood to the core, increased respiratory rate seen across the board. And then increases in pulmonary vascular pressures due to central blood redistribution from the extremities are kind of that big thing that we were talking about. And again, that just increases blood to the core, increases the pulmonary capillary pressure, and then alveolar hydrostatic edema is increased. So this is showing that the mean pulmonary arterial pressure or artery pressure and the pulmonary artery wedge pressure were compared to the cardiac output. So the control subjects were studied at rest and during exercise, whereas the SIPE susceptible subjects were studied only during exercise. And this was again to reduce the risk of SIPE in individuals who have experienced SIPE before. As Dr. Christensen pointed out, that's because one of the risk factors for SIPE is previously having SIPE. So accounting for the differences in cardiac output, the mean pulmonary artery pressure and pulmonary artery wedge pressure were significantly higher in the SIPE susceptible group than in controls. And you can see that in the red circles versus the blue circles there. We can then look at how sildenafil affected this. And after sildenafil, patients experienced mean pulmonary artery pressure that was significantly reduced, which was statistically significant. During the post-sildenafil exercises, neither the mean pulmonary artery pressure nor the pulmonary artery wedge pressure was significantly different from controls. So moving forward to why sildenafil may be working in this way. Why pulmonary vascular pressure may be accounting for why we're seeing SIPE in some of these individuals. So the number one would be the higher venous tone. So increased vasoconstriction in the extremities is shunting blood to the core. In swimmers, and often in swimmers that I've seen come out in the triathlons, you can't get a pulse ox on them because their hands are so cold. Interestingly enough, I've seen people, or many people actually, who've come out with symptoms of Raynaud's who haven't necessarily experienced that before, just because some of the water is so cold. So the water in the study was 20 degrees Celsius, but based on where you're swimming, for endurance swimmers, triathletes, or Navy SEALs down in San Diego, the water might be much colder. Higher blood volume, so that's higher blood volumes in the core. So again, shunting to the core and increasing your load that's going through the heart and then being pushed out to the pulmonary vasculature. Impaired left ventricular systolic function, low diastolic left ventricular compliance, and increased left ventricular filling pressures. So sildenafil, some of the theories going into why sildenafil was chosen for the study, and then how it's theorized to work in SIPE. So it decreases the resting mean arterial pressure and systemic vascular resistance, increasing cardiac output. This induces the increase in venous compliance. And this is in direct counteraction to what the proposed mechanisms are for SIPE. So you're having vasoconstriction in the extremities and the periphery, and shunting all of that blood to core. Sildenafil is increasing that venous compliance and decreasing the vasoconstriction. So hopefully you're keeping blood and just generally fluid out into the extremities and stopping it from increasing that alveolar hydrostatic pressure to push it into the lungs. This was shown in a follow-up in subject 3 from the study, who had experienced several episodes of SIPE during triathlons and then had no further episodes since using pre-race sildenafil. This has actually been talked about a couple times in the literature with case studies where individuals who've had SIPE 2 or 3 times come back after having used sildenafil and are not seeing any additional cases of swimming-induced pulmonary edema. So moving to validity and limitations. So potential subjects with comorbidities, Dr. Christensen talked about the respiratory complaints or conditions that individuals may have prior to going into a race, or that could predispose them to getting swimming-induced pulmonary edema. I thought the study was really great in that it looked at like forced vital capacity and all of the spirometry measures to ensure lung capacity and lung function was standardized between the two groups, the control and the symptomatic groups. But there wasn't specific testing for some of these, nor was there, at least talked about, questions on respiratory pathology, such as COVID. But there were questions on general medical history. The control group was 90% male in comparison with 40% male in the SIPE susceptible group. And then additional studies, again, have listed female as a risk factor. Subjects were greater than 55 years old. Endurance athletes, at least that I've seen, can be going much higher than this. Being down at the St. George Ironman when it wasn't in Kona was really great to see, and kind of pushed me when I saw like the 95 and 99-year-olds crossing the Ironman finish line. And I was like, okay, I should probably go on a run after this. But then variations in fitness. There was a very good description of each of the athletes coming through in the symptomatic SIPE group or previously SIPE group. There wasn't that same description of the individuals for the control group. And then accounting for differences in water temperature. So we know that the standardized 20 degrees Celsius water temperature was used in this study. But I think moving forward in literature, it could be very interesting to see it at different water temperatures. Additionally, having a better understanding of what type of wetsuits they were, and Dr. Moon, you may be able to, pull that right out as well. But like the thickness of the wetsuits, and then how that correlates to the tightness of the wetsuits as well. So next steps. This study was amazing that it confirmed that SIPE is a form of hemodynamic pulmonary edema, helping to clear up the murky waters of the pathophysiology of SIPE. It also said that the reduction in pulmonary vascular pressures after sildenafil had no adverse effects on exercise hemodynamics, and that it may be useful for site prevention. So the population and incidence is still under investigation, and there's a growing pool of evidence for sildenafil use in site prophylaxis and treatment, and future studies linking things like nifedipine, similar to how HAPE may be treated, although very different mechanisms, and future studies investigating the diagnosis or prevention based on risk factors are needed. And that is my journal club.
Great job. I read through the article just again this evening to refresh myself, and when you are actively reading it, some of the physiology can be a little hard to tackle. So great summary there. Any questions while it's fresh in all your minds?
So I'm just gonna disclaimer this with I'm an EMT. I'm in medic class right now, so please forgive my ignorance on some of this. But so one of the questions I had was sildenafil versus nitro, with the being a vasodilator. I know that sildenafil will act more towards like on the pulmonary side, but could you elaborate more on that, or just thoughts?
Yeah, we picked sildenafil because it's a known venodilator. Moreover, because it doesn't affect exercise capacity. Whereas the other drug that has been suggested in the literature by Dr. Peter Wilmshurst is nifedipine, and nifedipine is a negative inotrope, so which sildenafil is not.
Interestingly, sildenafil, sometime within the last 2 years, there's a study published in use of sildenafil to treat HAPE. So it's been used kind of more and more, at least in this study. It sounds like it's been used actually prophylactically now, at least in SIPE. But it's just, I had somebody in a past presentation actually mentioned that we're all diving. It's just what altitude you're at. So it's just kind of, it's just interesting. The pathophysiology can be treated with similar drugs depending on the circumstance. But that was a great question, Ian. And so that makes a lot more sense now that when you think about like which people are going to be using this. Any other questions on the article? And Dr. Moon, since this article, has any further studies been done on sildenafil in this process?
Yeah, can you hear me now?
Yeah.
Okay. We actually did a randomized crossover study that we used the same model, 40 minutes, head out, immersed, exercise in 20 degrees centigrade water. And we picked individuals who'd had SIPE before, and it was not a positive study. And I think there were several things wrong. Number one, we got the grants, and right then COVID happened. And of course, people weren't doing any triathlons. So it was very hard to recruit subjects. It was underpowered, I would say. And I think the model in retrospect that was actually too severe, and that is head out immersion has an additional risk factor, and that is the negative static lung load. That is the difference between the median extrathoracic pressure and the airway, which is, in tall individuals, maybe 15, 20 centimeters of water. Just at the time we started that study, there was a study from France in which they did a rebreather study in a swimming pool where they put the counter lung either anteriorly or posteriorly, and I think it was a crossover design, and they examined each individual after, you know, a long swim. I don't remember how long it was, but they found a lot of B-lines in the group where the counter lung was on the back. In other words, exactly the same negative static lung load that exists with head out immersion. So if I had to do the study again, I think I would do a full submersion like we did with the study that Harrison just described, or even better, do a study at buds where you have a large N, and it would be, at least in principle, very easy to come up with a well-powered epidemiologic study.
Is there any, since this is wilderness medicine, I know we all work clinically in various settings, but other than maybe bringing a port of care ultrasound, like a portable device, to like field care, other than applying oxygen, maybe a CPAP, is there anything really you can do in the field that would provide treatment on scene?
Well, the most important thing is getting the person out of the water, and that reverses the hemodynamic problem that caused the issue to begin with. Unless you have somebody who develops an acute myocardial problem like Takotsubo.
I would also say to that, I think it's very important to like look at your patient population. In working with all of the Ironman athletes for some of our research, they all want to go back into the water. Every single one of them gets pulled out. And if they're pulled out, we've built it into the protocol that they have to go through the study or at least get ultrasounded to get kind of the care. And the first thing we see is like pulling the wetsuit off, and none of them want to do that. For us, it's to ultrasound them, but secondarily, they're all wearing tight wetsuits, and it's increasing that compression. So if you're able to send blood back, you're still keeping the chest tight, even though you're out of the water. So talking to them, talking about swimming-induced pulmonary edema, which a lot of triathletes are pretty familiar with, but getting that wetsuit off and warming them up.
Folks, I'm going to have to sign off now, but thank you for inviting me, and it's been a delightful experience. And both presenters did an extraordinarily good job.
Thanks for joining, Dr. Moon.
Thank you, Dr. Moon.
Has anybody, I suppose maybe other than Harrison, because he's studying this in the field, encountered patients with this? This might be something where we might not know that we've had somebody with it before, because this would be something that you just, if you don't know it exists, you don't know to even consider it. So hopefully at least leaving this, you'll know that, hey, you got a patient who is swimming and they're coming in and it doesn't seem like a drowning picture. They're otherwise fit. So you're like, why in the world is this person having pulmonary edema? They didn't get Narcan in the field for an overdose. So like, they just now knowing about it, you can at least hopefully be more aware that it's a possibility. I don't believe I've personally taken care of anybody with it. I'm having my slew of other types of pulmonary edema, but Harrison, in your experience, what have you encountered? And Matt too, if he's, I think, yeah, Matt's still here.
Yeah. So I actually have and if I could share for a sec, I can just pull up.
Yeah.
This is something I presented at CU a couple of weeks ago. But this is just a quick case that we had. So I think we saw in our last enrollment, we brought in 70 individuals. I think we had about 22 or 23% present with B-lines consistent with pulmonary edema. And about half of those were symptomatic, half were not. So this was just a case of, it was a half Ironman, 27-year-old female from Rochester, dropped after the 5th buoy, presented with a slight wheeze. Vitals were looking good. She was just out of the water, so maybe heart rate a little elevated, and only on Zyrtec. This was her 4th Ironman, but she'd been training for about 6 months and really presenting just to us with a slight wheeze. But this is what she ended up presenting with. These were her lung fields, and the number of B lines in each lung field. So kind of fulminant B lines presenting on both sides, which was really, really interesting. So this was actually a lot of the type of patients that we were seeing. Was individuals who came out of the water, just weren't having a great feeling. You know, they come up to us saying, I just have a little cough, or today's not my day. I can't do it. No history of lung issues before. Not many of them ended up needing to go on to CPAP. A lot after 10 minutes out of the wetsuit and just in normal conditions, we're good to go after that. And we sent them home with instructions like, if you start coughing up anything, go to the ER. But about 20% were presenting with those B lines. So it was really interesting to start to kind of look at asymptomatic individuals and see how many actually present with some sort of fluid in their lungs that may or may not have been there before. We can't tell. But also anyone with cardiac complaints, we do a 12 lead on, and they didn't have any cardiac abnormalities. So it was very interesting.
Yeah, I think we've got a long way to go, and I not that I want to have a patient with this condition, but I'd be interested in treating somebody with this. Any questions about IPE in general? I think we've covered a lot pretty quick. It's only been an hour, but we've really hit the ground running here. And as far as I know, we've essentially covered our content for the session, unless Matt and Harrison have anything else they'd want to discuss. Okay. Well, I think as far as this topic goes, I think we've covered a ton. Thank you very much to Matt and Harrison for presenting, and I think you were both included in the email with Dr. Moon, so I hope you take advantage of connecting further with him, because it sounds like you could both really maybe dive deeper into this research field. With that being said, before ending this session, I just wanted to mention the next month's upcoming topics. So next month we are covering spinal cord injuries, and we have the lead author, Dr. Seth Hawkins, joining, who's pretty well known with Wilderness EMS, especially in he's like the state park director for all of North Carolina. And then the month thereafter, I think, should be quite fun. We are having, again, Seth Hawkins, Will Smith, the director of the Grand Teton National Park, and we're having Ben Abo, very well known in Florida and Wilderness EMS, Michelle Curry, the medical director of all the National Forest Department, and potentially David Pfeiffer, who's very active in Kentucky. So maybe really well-known, strong panel for January, joining for like search and rescue and Wilderness EMS. So I hope you all join for those ones. Those should be pretty cool. Soon I'll be sending out the updated registration forms and information for the next 6 months, because next month ends the current 6-month cycle. So you should be expecting your FOM certificates end of December, early January. I'll crank those out once we finish December. Otherwise, looking forward to seeing you next month, and thanks for joining. I'm going to end the recording. If anybody wants to chat after, we can, but I'm going to end recording.
I've got another question, more on just like the connecting the